Thanks for this opportunity to talk to you about some of our experiences in the rheumatoid arthritis case study today. My name is Marie Falahee, and I'm representing the clinical academic group at the University of Birmingham who are leading the delivery of this core case study for Prefer. I'm also an academic lead for our local patient partnership, so a rheumatology research patient partnership. So they support patient involvement across all of our group's activities. So that includes discovery science, experimental medicine, and applied research. So we've got quite a bit of experience of involving patients in our research in a number of different contexts, not just in preference studies. I'm having trouble advancing my slide. Sorry about that. So just to introduce the clinical background to our case study and why we're interested in it. So it's now widely established that early treatment of rheumatoid arthritis leads to improved outcomes. And this has led to the idea that there might be opportunities to intervene and treat people before they're diagnosed with rheumatoid arthritis. So in kind of when they are perhaps at risk of developing the disease. And this diagram kind of illustrates key at-risk groups that have been identified and where investigations of preventive interventions are ongoing. And the first of these, so people with a family history of rheumatoid arthritis have an elevated risk status, and this is one of the groups that we're particularly interested in our study. So the clinical objective of the Prefer RA case study was to assess preferences of people who are at risk for preventive treatments of rheumatoid arthritis. And of course, because this was a Prefer study, it was also designed to address lots of methodological research questions as well. For example, comparing a discrete choice experiment with a threshold technique and assessing the ability of a number of measures of cognitive and psychological constructs for their ability to account for preference heterogeneity. And we're also comparing samples in 3 different European countries and also comparing 2 different types of samples. So we recruited members of the general public from survey panels in each of the 3 countries and asked them to imagine that they were at risk of RA. And we also recruited clinical samples of confirmed first-degree relatives of RA patients through rheumatology clinics. So just to move back to the focus of today, which is patient involvement. So we were lucky to have support from an international group of patient research partners for this study. There were eight of them representing the UK, Germany, Netherlands, and Sweden. And some of those we knew because they were members of our local group, but some of them we had kind of developed ongoing relationships with through their involvement in previous European studies that we've been involved in that focus on the kind of prevention of RA space. So this kind of really facilitated their involvement right from the early stages. I mean, really even before Prefer began, because of those kind of previous experiences, we knew that these areas were important to them and that this was something of interest to them. And that meant that they were kind of very closely tied up in the development of the clinical objectives of this study. And indeed pointing out that this kind of area was important for us to be doing. And they were also, some of them were also able to provide input to the funding application for Prefer. So having those kind of established relationships in place really helped to cement the role of patients in our study from the very earliest stages. So I'm going to try and focus on aspects of the RA case study that were slightly different from the other case studies, because of course, our study involved a qualitative and a quantitative phase in the same way the others did. And many of the activities that we've already heard about will have been going on in our study as well. But I'm going to try and focus on things that are a little bit different rather than repeating what you've already heard. So in our sample, a kind of unique feature really is that we weren't recruiting patients. We were recruiting first-degree relatives, a clinical sample through rheumatology clinics. And so this is a kind of, this isn't a patient preference study, if you like, in a way, but we were recruiting indirectly through patients. So we were approaching patients when they come to clinic and asking them to pass on an invitation to take part in the study to their relatives. So it was really important, actually, that the materials we used and the approach we took to introduce patients to the study were sensitive to their needs and concerns and were acceptable to them. And our patient partners were really kind of played a crucial role in developing the kind of recruitment procedures that we undertook because of this. Crucially, they pointed out to us that a rheumatoid arthritis patient might never have considered that their relatives might be at risk or have an elevated risk of getting RA in the future, and that this might be something that could provoke some anxiety and concern. And so, we were able to try and find ways to address this possibility. And we provided kind of links to information and support that could allay some of those concerns. One of which was the picture here. It depicts a booklet that we developed with some of our patient partners in a previous project called EuroTeam, which kind of tackles some of these issues and hopefully will have been useful in this respect. We also provided a named contact so that if people were still really concerned, that they could get in touch and have some support in that way. So because we were recruiting people who didn't have the disease, who weren't patients, it's kind of different from a normal patient preference study because our participants don't have the disease. They may not have any experience at all of the disease. And so it's really important in this study that the information we gave to participants in both the qualitative and the quantitative phases addressed this and kind of gave just the right amount and the right kind of information about RA and the disease background to enable them to make informed choices. So we worked very closely with our patient partners, and some of them provided a lot of input into the focus group schedule, how we described rheumatoid arthritis, and also how we described the medications that we were asking our participants to discuss and consider. One of our patient partners who's worked with us before contributed to the analysis of the qualitative data. So she helped to validate the coding framework that we used to code and classify the data. And we also asked our patient partners to do a kind of rank ordering of all the treatment attributes that were identified in the qualitative phase, and also consulted them about which ones we kind of finally selected to go into the quantitative survey, and also which ones we should kind of hold context, hold kind of or control in the choice tasks scenario. And like we've heard before, they were also involved in developing how we presented the attributes to participants, and also in developing a lay summary of the results. In the quantitative phase, again, we needed patient partners to really work closely with us to make sure that the descriptions of RA and the disease background were appropriate. because many of the participants, some of whom were members of the general public, won't have had any kind of first-hand experience of this disease. And so they were able to kind of make really key contributions. So they added descriptions to the background information of how the kind of early symptoms of RA might affect someone's day-to-day activities. And we also, in our first draft of the quantitative phase, we included some diagrams depicting the kind of joint erosion that can happen in RA, which seemed to us to be a good way to convey information about how serious the disease is. But they kind of pointed out that these diagrams were very unhelpful. They were very medicalized and depersonalized, and there was a danger that some of our participants might kind of disengage completely and think that this just wasn't something that's relevant to them. So on the basis of their advice, we removed the unhelpful diagrams from the survey. We also changed the choice task in that we were originally planning to ask people to imagine that they had been identified as having a 40% chance of developing RA in the future, and had been asked to kind of consider whether they would like to take a preventive treatment to reduce that risk. And the qualitative results and the discussions we had with our patient partners indicated that really, we needed to increase that baseline risk status for people to engage with the questions, and that at 40% risk, that very few people would be likely to accept a pharmaceutical intervention to reduce their risk of rheumatoid arthritis. So we changed the choice task on the basis of those kind of discussions. Also, like the others we've heard of, our survey was way too long, and we worked closely with our patient partners who advised us on which aspects of the survey that were appropriate to remove to shorten it. And we had originally intended to incorporate health locus of control measure, and on the, we were advised by our patient partners that seemed the least appropriate measure to the study of objectives, and so that one was removed. And then, like the other studies, we also revised the wording and the content of the survey on the basis of their input, and involved our patient partners in some of the think aloud interviews we used to kind of pre-test it. So in just a very quick summary of all the ways in which our study, we feel, has benefited from our excellent patient partner input, we kind of really were sure right from the start that our study was kind of important to them, it was relevant and something that we should be doing. And they helped us to identify and address ethical issues when we were developing our recruitment procedures. They increased our participants' ability to make informed choices by providing them with appropriate information about what it's like to have RA. And also by kind of tweaking the choice task scenario, they decreased the likelihood that we would collect uninformative data, because no one would choose a preventive intervention over opt-out in some situations. And so I'm going to skip to the next slide because we're running out of time, and to say thank you to all of the case study team, especially the patient research partners who I've really enjoyed working with on this study.